types of ADPKD, which most people in the audience probably are well aware of, and then we'll jump into the pregnancy and preconception considerations. So how common is ADPKD? As you know, that stands for autosomal dominant polycystic kidney disease. The incidence, meaning how many new cases are there per year, are about 1 in 800 to 1 in 1,000 live births. The prevalence is close to 40 per 100,000 people, meaning this is how many people there are at any one time with ADPKD. It is, as you know, the leading cause of end-stage renal disease, kidney transplant, and hemodialysis. And obviously it affects the kidneys, causing enlarged cysts, can cause high blood pressure, hypertension, pain from the cysts in the kidneys, kidney stones, urinary tract infections and cyst infections, in some cases carcinoma or cancer of the kidneys, and renal failure. But there are also manifestations outside of the kidneys, including cysts in the liver and pancreas, cysts in the seminal vesicles, which are part of the male reproductive system, and the arachnoid membrane, which is in the brain. There can also be aneurysms or dilations of blood vessels. These can happen in the brain in the form of intracranial aneurysms or in the aorta, the large blood vessel that takes blood away from the heart. And those dilations can be particularly life-threatening because they can dissect, which means tear a hole sort of in the side of the aorta and cause bleeding outside of the blood vessel. Cardiac issues, including valve issues in the heart and coronary artery aneurysms, which are the blood vessels that bring blood to the heart muscle. And then in the colon, there can also be diverticulosis and diverticulitis, so sort of outpouchings of those tissues in the body, which can cause infections and pain and other issues. There are varying criteria for diagnosis of PKD, of autosomal dominant PKD. Many times it depends on if somebody is considered quote-unquote at risk, which basically means that they have a family history of PKD or a mutation in a gene related to PKD. So in children and infants, although this doesn't present typically at that age, it can. And if you see large echogenic kidneys in a child who has, for example, a parent with PKD, then that's concerning. The other criteria are based on the number of cysts that are seen, at what age, and what imaging modality, and so there are very specific criteria for that, as well as other things in the history that might make it more suggestive, such as cysts outside of the kidneys in the areas that we mentioned previously, even just enlarged kidneys or an enlarged liver on a physical exam by a physician, people with high blood pressure diagnosed before the age of 35 without any other medical reason for that diagnosis, and obviously a family history of PKD are very strong indicators if you combine some of these things together. And as we stated, it's called autosomal dominant PKD, in contrast to autosomal recessive PKD, which is a little bit of a different animal. Dominant is an idea in genetic inheritance in which, just to take a step back, in all of our body, we have our genes, our genetic instructions. We always have 2 copies of every gene. So 1 copy comes from our mother and 1 copy comes from our father. In dominant conditions, you only need 1 of those copies to have a mutation in order to have the condition, which is in contrast to recessive conditions. In recessive conditions, you need both copies to have a mutation. So you need to inherit 1 from your mom and 1 from your dad in order to have the condition. So in dominant PKD, we know that most of the time your mutations are inherited from one parent or the other, but 5 to 10% of the times a mutation can be de novo, which means new in the individual. They are the first person in their family to have it. It didn't come from either parent at all. We also know that there can be differences in the presentation of PKD in people, even within the same family. So that's what we call phenotypic variability. So one person may have cysts in the kidneys and liver, where someone else may have cysts in the kidneys and intracranial aneurysms. And so even with the same mutation, there can be different presentations. There are 2 genes we know related to PKD, autosomal dominant PKD, PKD1, which is the gene that causes most cases, up to about 90% of cases, It tends to be the more severe cases, and the average age of end-stage renal disease is dependent on the type of mutation someone has. Another word for mutation, and the more modern word we use, is called variant. So those who have truncating variants, meaning the protein gets cut off earlier than it should when it starts to be made in the body, have a earlier stage of end-stage renal disease, whereas those who have non-truncating variants, meaning the protein is still made, but it's just made in an abnormal way versus being cut off early and not being made at all, have a later stage of end-stage renal disease, closer to 68 years of age. Type 2 PKD is caused by mutations in PKD2 gene. It's about 10 to 15% of cases, and the average age of a transplant is around 69 years of age. Most people who have autosomal dominant PKD will need dialysis starting at some point over the age of 45. And although the genetics can have a lot to do with the prognosis and sort of how severe the kidney disease is, other things like environmental factors, meaning what sort of damage the kidneys are already subjected to due to medications or diet, etc., may also play a role as well. So we breezed through that because I was hopeful that most of you were aware of those things. The point of this talk was to talk more about the pregnancy and preconception considerations. So one of the big things we think about in pregnancy, people with or without PKD, is hypertension and preeclampsia. You may have heard a lot about preeclampsia lately. It's something that's talked about a lot related to the increased risk of Black maternal morbidity and mortality. And in fact, just recently in the news, a U.S. track and field star who won numerous medals in the Olympics died of what we think was eclampsia at her home. So it's a big cause of morbidity and mortality, not just for Black women, but for all people who are intending on having children. So in those people who have PKD, there's very little data actually out there about pregnancy and reproductive issues. So one paper that was written in 2008, actually from colleagues at my institution, was regarding hypertension and preeclampsia in people with autosomal dominant PKD. And what they found is that about 15% of the time, people who did not have hypertension, although they did have PKD, had a 15% chance of developing hypertension in pregnancy. About a quarter of pregnant people had complications of their hypertension during pregnancy, and 11% had developed preeclampsia, which we'll talk about what that is in a moment. People who went into pregnancy with normal blood pressures and then developed hypertension or preeclampsia during pregnancy had a very high chance, 88% chance of developing chronic hypertension, immediately after, so continuing to have hypertension for the rest of their lives after delivery. And those who never developed hypertension or preeclampsia during pregnancy still had a very high chance of developing chronic hypertension later on down the line, about 62%. We know that there also was an increased risk of acute renal failure during pregnancy. And in the people in this study, all of those were ones who had preeclampsia during their pregnancy. So preeclampsia likely increases your risk even more for renal issues during pregnancy, or after pregnancy, sorry. Preeclampsia is defined as new onset hypertension and proteinuria or other evidence of end organ damage during pregnancy after 20 weeks of gestation. So anything that happens before 20 weeks, high blood pressure that develops at that point is considered chronic hypertension. But after 20 weeks, if you have this combination diagnosed with preeclampsia, it can obviously be challenging in someone who already has high blood pressure issues. So those definitions change as far as how high the blood pressure is and what the difference is between your baseline and the blood pressures in the pregnancy after 20 weeks. So it's really important to have discussions with your doctors about pregnancy if you have PKD and hypertension issues before getting pregnant, so we can make sure it's clear what is your baseline and what is not. Importantly, preeclampsia, although we talk about it just in pregnancy, it actually can occur up to 6 weeks after delivery. So people with PKD who are especially at high risk of developing preeclampsia, it's really important to know you're not really out of the woods until after that 6-week period. The symptoms that patients with preeclampsia complain of are headache that doesn't go away with normal medications like Tylenol, vision changes, which is like spots in your vision, double vision, acute or sudden onset of chest pain or shortness of breath, particularly at rest, right upper quadrant pain in the abdomen. So the right upper quadrant is right under the right breast area. That's where the liver is. Preeclampsia can affect the liver and cause hematoma, like a bleeding around the liver, and so that can cause pain. And then, although not part of the stroke criteria, also we may be more concerned if there's a sudden onset of waking from worsening edema or swelling in the hands and face, so non-dependent areas. It's obviously very common in pregnancy to have feet and leg swelling, but if you get swelling in places that are not due to gravity, that may be more concerning if the kidneys are not working well. And if untreated, preeclampsia can progress to eclampsia, which are these issues we've discussed above, plus seizures. And obviously that could be life-threatening. And in order to risk stratify, we separate preeclampsia into different categories. Preeclampsia without severe features and with severe features. So preeclampsia without severe features is the hypertension and proteinuria. But the severe features are really high blood pressure, so greater than systolic of 160 or a diastolic of 110, it's either or. Thrombocytopenia, which is low platelet count, less than 100. Transaminitis, which is elevation of the liver function studies, and the way we define that is twice the upper limit of the normal range for the lab that blood is drawn in. Worsening renal function, so doubling of the serum creatinine, persistent pain in the right upper quadrant where that liver is, pulmonary edema, which is fluid in the lungs, or visual changes like we discussed before. So if you have the blood pressures and the proteinuria and any one of these things, you have a diagnosis of preeclampsia with severe features. And preeclampsia with or without severe features has multiple complications in pregnancy. These complications can be for the fetus as well as for the pregnant person. So for the fetus, we worry about growth restriction, so very small babies, which can be problematic because they may not have as much reserve or be able to sort of handle the fluctuations that can happen with labor and delivery. Preterm delivery, often this is due to the preeclampsia or the growth restriction that necessitates an earlier delivery. Abruption, which is where the placenta separates from the wall of the uterus and causes bleeding. It's a life-threatening complication for the fetus and can also be for the pregnant person, and so it typically necessitates an urgent delivery, especially if it's a large eruption. Respiratory distress, that can be just due to the fact that the fetus was born early, and we know that the lungs are the last thing to develop in fetuses before they're born, and so an early delivery can affect that breathing. And then stillbirth. Stillbirth can be due to abruption, it can be due to imperfect perfusion of the placenta, so the blood flow through the placenta to the baby, because of the hypertension that is caused by the preeclampsia. In the pregnant person, obviously high blood pressure, as we talked about, even if it wasn't present before, this future increased risk of hypertension and cardiovascular disease, the kidney damage and chronic kidney disease, especially in those that have pre-existing kidney disease, liver failure potentially, cardiomyopathy, which is enlargement of the heart, which can lead to heart failure, stroke, seizures, which are part of the eclampsia picture, and then also diabetes, even though it seems sort of separate, it does seem to be an association with an increased risk of diabetes, especially later in life. The treatment for someone who has preeclampsia during pregnancy is delivery. So we watch these pregnancies extremely closely. Those who have preeclampsia without severe features can typically go to 37 weeks. Just for reference, your due date is 40 weeks. So those patients get delivered 3 weeks early. And those with severe features, we recommend delivery by 34 weeks, so 6 weeks early. Obviously, this can change if things are changing with the progression of the preeclampsia, and delivery needs to happen earlier than that, then that may be part of the discussion. And typically, since it can turn to eclampsia so quickly, or preeclampsia with severe features can just progress and make someone sick, without a lot of notice, we typically are at our institution, we're very strict with our monitoring and typically do inpatient monitoring. So if someone is diagnosed with preeclampsia with severe features at 30 weeks, they get admitted to the hospital until their delivery at 34 weeks. There are places that will do outpatient monitoring, but especially if someone's having a hard time adhering to doctor's appointments or medication strategies, then inpatient management may be the better option. Besides that, as we wait for delivery to happen, or if this is diagnosed after delivery, blood pressure management with IV or oral medications is needed, as well as every person with preeclampsia with severe features would receive IV magnesium sulfate. If it's before delivery, we give that medication like in the labor until delivery happens. If it's after delivery, then we usually give that medication for about 24 hours. It makes you feel really groggy, really warm and flushed, and levels of magnesium are monitored because too high levels can also cause complications regarding sort of respiratory depression and other issues. And so keeping an eye on the kidney function is really important because that's how the magnesium clears the body. Other issues outside of the hypertension and preeclampsia in pregnancy are issues with the kidneys. So kidney function and cysts can be affected. Significant renal disease before pregnancy has an adverse effect on long-term renal and fetal outcomes. So again, another reason why meeting with your doctors and having a plan before pregnancy if you have severe kidney disease is important. If chronic hypertension is known before and is treated at the beginning of pregnancy, then that may improve these outcomes. From this small group of individuals in the 2008 paper, it seems that people with stable renal disease do not have worsening renal disease in pregnancy, especially if we're keeping a close eye on any hypertensive issues or issues with preeclampsia. And creatinine does not seem to worsen except after people have had 4 or more pregnancies. And so, people who are just starting out should not really change their kidney function. Oftentimes, there's a lot of concern about medications and issues in pregnancy in general. And so things like UTIs, kidney stone, and cysts may happen, and more likely to happen in those with PKD. And we would treat those like we would treat in any patient. We would recommend safe medications, antibiotics, and those who have UTIs. It's always possible that a UTI can become pyelonephritis or a kidney infection in pregnancy, which can be can make somebody very, very sick in pregnancy. It can cause pulmonary edema, fluid in the lungs, and sort of systemic sepsis, and so we treat that very, very seriously. But otherwise, we treat these things the way we treat them in non-pregnant individuals, and for those that need it if the pain is so severe, narcotic medications are okay to use, especially for short-term reasons, and we're just trying to get through the pain. Liver cysts are also obviously something in PKD. Multiple pregnancies can cause hepatic cysts, and we know that estrogen exposure may have an effect on the liver and cyst formation, and so those should just be monitored, before and after pregnancy. For the fetus and neonate, we know that, again, ADPKD mostly does not present in children and babies, but there's about 2% of cases in which, if it does present in the fetal period with enlarged pathogenic fetal kidneys, there's an increased risk of mortality for the fetus or newborn. So 43% of those have died within the first year of life, and 2/3 have had complications by 3 years of age. That's if the fetus has PKD. If the fetus does not have PKD, then the considerations are around the growth issues, so small or fetal growth restriction, like we talked about, prematurity due to complications from preeclampsia, for example, or the growth issues, sometimes a NICU admission, particularly if the fetus is premature, or if it's pretty severe growth restriction because small babies aren't able to always regulate their temperature or feed appropriately or maintain their blood sugars appropriately, so they need ICU treatment. There's this questionable association with maybe fetal malformations that is not really been clearly established yet, but something that is mentioned in some papers. And then in some cases, neonatal death, especially if the birth restriction is quite severe or, abruption or something like that has occurred. In pregnancies, the way that we monitor them is another reason why it's important to get care early in pregnancy is we want to establish baseline labs. We call them baseline preeclampsia labs. So let's look at your hemoglobin and platelets because those can be affected by preeclampsia. Let's look at your liver function, your creatinine, and let's collect a 24-hour urine to know what your baseline proteinuria is. So these things may be checked later on throughout pregnancy if we have concerns that either their hypertension is worsening or that preeclampsia may be developing. But if we check those things for the first time when that happens, it would be unclear to us if this was your baseline or this is now worsening of your kidney issues and the preeclampsia. And so really important to get that done at the very, very first doctor's appointment. We now know that prenatal aspirin, 81 milligrams, it's also sometimes called a baby aspirin, can be helpful to prevent preeclampsia from happening. The thought around preeclampsia is that it has something to do with how the placenta implants into the uterus, and that those blood vessels that are sort of digging into the uterus are formed a certain way, and for those that develop preeclampsia, they're formed in a way that restricts blood flow and causes these hypertension issues. So the thought is that prenatal aspirin given early, starting early in pregnancy, helps how that bonding happens. It helps to make it less likely to cause this constriction in the blood vessels. And so prenatal aspirin is now something that we recommend starting before 16 weeks in pregnancy. It's 1 pill a day, every day until delivery. It does not have a lot of increased risk or other complications in pregnancy and has really been a game changer in decreasing the risk of developing preeclampsia or the severity of preeclampsia. And then during a pregnancy, we follow fetuses with growth ultrasounds, and those are typically every 4 weeks if things are going well, maybe down to every 2 or 3 weeks if there's some concerns about growth. And particularly if growth concerns are developing, then uterine artery Dopplers are usually added on, and that's where they look at the blood flow through the umbilical cord to make sure that the blood flow is moving forward towards the fetus and not stopping or moving back intermittently, which can be a sign of resistance within the placenta. There also is an assessment of the amniotic fluid. Amniotic fluid is a reflection of the fetal, amniotic fluid is basically fetal urine. And so if the baby's kidneys are not working well, then that may decrease amniotic fluid. That's not something to worry about in a fetus that does not have PKD. But in a fetus that does not have PKD, whose mom has preeclampsia or kidney issues, we may just be worried about that perfusion of the blood flow through the placenta, which is part of what's helping the baby make the urine as well. Blood pressure management in pregnancy, so there are medications that we consider to be safe in pregnancy, so another reason why meeting with your doctor before pregnancy is important. Oftentimes we want to switch people from their blood pressure medicines they're on any to one that's safe in pregnancy and that we can continue in pregnancy. The two that are typically used are labetalol and nifedipine. But there are others that can be used, and the dosing just depends on, sort of what's happening with every individual. Oftentimes, if people need IV medication, there's a whole protocol about how to give either labetalol or nifedipine, sometimes hydralazine in an urgent setting. And it's really important to keep an eye on those blood pressures in the first and second trimester. In the second trimester, there can be a normal dip where the blood pressures get a little bit lower. That's just physiologic. It happens in pregnancy. But especially in people who have higher blood pressures, we want to avoid too low of a dip because that can cause what we call suboptimal placental perfusion. Like the placenta is used to a particular force or a particular blood pressure to push blood into the placenta. But if it drops suddenly, then that may decrease that blood flow to the placenta and therefore compromise the baby. So important to keep an eye on that. We have different targets for blood pressures for people with or without PKD in pregnancy. So if you don't have PKD less than 140 systolic or less than 90 diastolic is what's recommended. But in people with PKD, we want to keep it a little bit lower, a little bit closer to what it should be non-pregnant in order to continue to keep the kidneys healthy. And then delivery is usually fine to be done by vaginal delivery, assuming the baby's head down and there's not an urgent indication for a C-section. People with PKD and with preeclampsia are more likely to undergo an induction of labor because of growth restriction or preeclampsia. And induction of labor is just when you get admitted to the hospital to get medications in order to make your labor start versus labor starting on its own. But people with PKD and with preeclampsia are more likely to undergo cesarean section for the appropriate indications. So abruption, worsening preeclampsia that's not improving, fetal growth restriction, and the fetus is not tolerant to labor by, demonstrated by fetal heart rate abnormalities, things like that. So we wouldn't, out of the box, just say someone needs a C-section just because they have PKD or preeclampsia. So those are the pregnancy considerations. We'll move on to the preconception considerations, and then I'm hoping that there will be questions at the end. I think there's a break after this, so hopefully, because we started a little bit late, if people have questions, I'm okay to stay past the 10 till time. So we've talked a lot about the pregnant person and what's going on with them, but in the preconception period, there can be some male reproductive considerations. We talked about those seminal vesicle cysts that are possible. So the seminal vesicle is here, there's a circle around it here. So in this diagram, this is the bladder, this is the prostate underneath, and the seminal vesicles sit just behind the bladder. That is part of the pathways to the testicles where the sperm are formed, and then they travel up this tube called the vas deferens, past the seminal vesicle, through the prostate, and then out through the urethra and out of the penis. And so there can be issues with sperm motility, either sperm that are like dead, unfortunately, that's what necrospermia means, or not moving well. That can happen as they're forming in the testicle. And then the seminal vesicles can be dilated or cystic, which can affect sort of the milieu that the sperm are in. And this can be seen, somewhere between 40 to 60% of men with PKD. There can also be cysts in the ejaculatory ducts, which make it complicated or harder for the sperm to leave the body. In the female partner, there aren't really known issues with fertility. As long as there's normal renal function, there's a thought that perhaps there might be this increased risk of ectopic pregnancy. So ectopic pregnancy is when a pregnancy forms outside of the uterus, oftentimes in the fallopian tubes, but there is not like a clear association around that. But again, important to check in with nephrologists. There should be renal ultrasound within 1 year of wanting to conceive to assess the cyst size. And we know that some of the newer medications are not necessarily safe in pregnancy, and so we need to stop those medications. We also would want to switch the medication that people are using for their hypertension. So if they're using an ACE inhibitor or an angiotensin, an ARB, then we want to make sure to switch that once the person is pregnant, especially if they have proteinuria. If there is no proteinuria, then those medications are, they're given to help prevent proteinuria from happening, and so it's safe to stop them prior to conceiving, and then, starting them on a safe blood pressure medication if blood pressure has become a concern. We would also recommend preconception MFM consultation. So MFM is a maternal fetal medicine specialist. They may follow somebody in a pregnancy, or may just have a consultation with them so that they can give advice to their OB/GYN. But this is the time to talk about all of the things I talked about already. What we would do to monitor the pregnancy, when we should do baseline labs, what things we should be looking out for, what medications we might want to use, going forward, to just make a plan in case hypertension develops or preeclampsia develops. Would also recommend meeting with an OBGYN for a consultation. They may work with your MFM doctor. The MFM may do some of this early discussion, but usually not. Usually they're focused on the medical issue. So an OBGYN can do the normal blood test that we'd like to do to make sure you don't have HIV and you don't have syphilis and that you are immune from rubella and chickenpox. But we can also do what's called carrier screening. So carrier screening is looking for autosomal recessive conditions. There's about 110 of them now that are recommended that every couple that wants to conceive consider screening for, and so that's a time to talk about that. And also to do lifestyle modifications that can make the pregnancy successful. So making sure we start out at a healthy weight, that we're incorporating some kind of exercise into our life, that diet is improved and we decrease caffeine intake, and obviously avoiding smoking and drinking alcohol as well as other drug use before conceiving and obviously during pregnancy. It's also a time to talk about genetic counseling and testing if somebody has not already had that. So genetic counseling is a process where we have a discussion about family history. We create this picture that you see here called a pedigree, which sort of outlines the people in the family, who's affected, who isn't affected, who has had genetic testing, who hasn't. We talk about risks, benefits, and types of results of genetic testing. So, and the cost of this type of testing. And so if somebody's interested in doing any type of diagnosis, either of an embryo, which we'll talk about in a little bit, or of a fetus, we need to know the genetic mutation that's being carried in the family. And so this process needs to happen in conjunction with a genetic counselor. It's best for it to happen before pregnancy. That way we have as many options available to us as possible and as much time available to us as possible. In a genetic counseling appointment, after that pre-test counseling, testing can be done, obviously, and then after those results are back, there's a discussion with usually a genetic counselor or a physician like myself, a geneticist, to talk about the results and make sure that all of the specialists that need to be involved are involved, and also to help coordinate what we call cascade testing, which is testing of other family members, or at least giving other family members information in case they aren't interested in testing. Seeing a genetic counselor or a geneticist does not mean you have to do genetic testing. It's more about giving you information and making sure you feel like your questions have been answered, and then if you want testing, that's something that can be done. So the advantage of doing all of this before pregnancy and having established what the genetic mutation is in an individual PKD is that the option of in vitro fertilization is available. So that's a process in which medications are given by a reproductive endocrinology and infertility, or REI specialist, and they can stimulate the ovaries to create lots of eggs. You then have a procedure under anesthesia to retrieve those eggs, and then sperm is also obtained, and those get incubated or like mixed together in the lab, as I tell my patients, and embryos are created. Those embryos can then be tested to see if there are any genetic mutations in the embryo. It's not exactly genetic mutations, but they can identify which embryos are likely affected and which embryos are unaffected. And then you can use the embryos that are unaffected to transfer those into the uterus to obtain a pregnancy. The embryos that are not being used at the moment, either the affected or unaffected ones, can then be frozen and used at a later date. So if you do this, oftentimes you don't have to do it multiple times, you just have to do it one time, this egg retrieval process, and then the embryo transfers can happen as time goes on. So this is the process of testing the embryos. It's called pre-implantation genetic testing. So after those embryos are made in the IVF process, a couple of cells are biopsied from the embryo. The embryos are then frozen, and then those cells get mailed off to a special laboratory that does genetic analysis of the biopsy to determine does this embryo seem to be affected or not affected. And then those that are not affected, as I said before, can be transferred. There are different words we use depending on the type of pre-implantation genetic testing, so you may hear those if you're going through this process or are interested in the process. PGTM is the one that's used for PKD. M stands for monogenic condition. Monogenic just means one gene, the PKD1 or PKD2 gene. But also this can be done for things like ruling out Down syndrome or other what we call chromosomal disorders in embryos. So sometimes people who are interested in just understanding, what the risks are as much as possible may want to do PGTA and PGTM prior to transferring back any embryos, especially if they have PKD and are at older ages where things like Down syndrome can be more common. And then there's another one called PGTSR for structural rearrangements, which are less common. The pros to doing this in vitro fertilization with PGT are that you can prevent the passing on of the PKD to your children. It also freezes time because we know that in women, as they age, their eggs can get more genetic issues, especially related to the chromosomal issues. And so the younger you are, the less likely that is to happen. And so you can sort of freeze time. When you get those embryos, you freeze them. They don't continue to age or those eggs don't change. And you can look for other conditions besides the PKD in those embryos. But the cons are that it's costly. It can be tens of thousands of dollars. It may or may not be covered by insurance. Even if parts of the process are covered by insurance, oftentimes the genetic testing part is not. You also need to freeze the embryos, and there's a cost to that, usually monthly or yearly. You may need to repeat the process, so you may not get enough unaffected embryos at the end of the process in order to continue, in order to have any unaffected embryos to use to repeat it. And it's not 100% accurate. There is a suggestion that you should be testing a fetus for the genetic mutation, even in someone that's done IVF with PGT, because it's only looking at a couple of cells and not all of the cells of the embryo. But the benefit of testing and knowing the genetic mutation for PKD allows you to either do the IVF process, or for those that don't want to do that, you can test a fetus early in pregnancy through a process called prenatal diagnosis, which allows you to make some decisions about continuing or not continuing a pregnancy, maybe delivering where there are a specialist, and what prenatal consultations need to happen. There's two procedures that can be done if this is what the route that someone wants to take. One is called CVS, like the store, or chorionic villus sampling, which is where a needle is put in either through the cervix or through the abdomen to get a small biopsy of the placenta. That is then sent off to a genetic laboratory to look for that specific mutation. The other option is called an amniocentesis, which involves a needle through the belly to get some of the fluid around the fetus. The differences in the procedures are mostly around the gestational age at which they can occur. The CVS can occur earlier in pregnancy, between 10 and 13 weeks, and an amniocentesis usually has to happen after 15 weeks. Both of them have a small risk of miscarriage, approaching 1 in 500, so that's 0.5% risk of miscarriage. But compared to the risk of having a fetus with the condition, which is 50% if you have PKD or your partner has PKD, some people are willing to accept that risk. The other options outside of these two are obviously in vitro fertilization with donor gametes. So if the female partner is the one who has PKD, you can use donor egg, or if the male partner, you can use donor sperm, and so you don't really need to go through that PGT process. Of course, adoption is also an option, and choosing not to have children is also an option. And we like to discuss all of our options with our patients. And it's important to recognize that we should talk about this decision-making process with patients. There can be normal feelings of failure of your body, or loss or guilt of not achieving motherhood, or gambling with one's health if you have PKD and you're considering if you want to have children. Everybody's decision-making is different, and there have to be complex decisions to be made sometimes around the pregnant person's health and survival and what that means in a pregnancy, and if there are complications, what to do, as well as what the outcomes are for the offspring. So passing this on to your offspring, you know, how does that feel? What does that mean? We know it's more of an adult onset condition, but you know, what are our thoughts around that? And fetal and neonatal outcomes, even if it's an unaffected fetus, we know that there can be some outcomes for them that are worth discussing. And it's important to talk about how the expectations of partners and families factor into how somebody feels about these decisions. There's also the attitudes of medical professionals, and we're always trying to give medical information and balance the risks of any appropriate or any approach to that of patient autonomy, so patients and being able to make their own decisions about what they want to do. And so each person's care should be individualized. We shouldn't, you know, treat everybody exactly the same, which is why it's important to have these discussions early and find doctors that you feel like you can talk to about these issues. So that's it. I know I went really fast, but I'm hoping we have time for questions. This is my contact information if you have any questions. And this is my oldest son. His name is Kane. He was conceived with IVF with PGT. My husband has PKD, which is how I've gotten involved in this conference. And you know, we use IVF to decrease our risk of him developing PKD. And we just had our second baby a few weeks ago, which is why I'm not here in person, who was also conceived the same way. So thank you for the time, and I hope there's some questions.